Now, I would like to briefly introduce our speaker, Dr. Renee Crichlow. Dr. Crichlow is the Director of Advocacy and Policy for the University of Minnesota Department of Family Medicine and Community Health. Dr. Crichlow, you may now have the floor.
Thank you, Sam. And I really appreciate you guys inviting me to the conference. If at any point you can't hear me well, just make it known. You can also text me. So welcome. Nothing like some health justice on a Saturday afternoon. It's a good time, good as time as any. As I mentioned, I am actually transitioning my jobs. I'm just moving this weekend from Minnesota to Boston. I will be the incoming Vice Chair of Health Equity for Boston University Department of Family Medicine. And as I said, I appreciate the opportunity to give this presentation. I do a lot of, I tell stories and I show pictures. There won't be a lot of tables or graphs or even numbers. I think that we actually do our best in changing the world by sharing stories. And as physicians, I think one of the most important things that we can do is amplify the voices of patients in the communities that we serve. For all of the paintings in this presentation, they are either by Glory Tuit or Amir Kadar, and there'll be their contact information at the end. And to describe the pictures are actually very challenging, but all the portraits are basically people of color being fierce and unafraid. So that's generally what they'll be. I think it's important when we're sharing stories to understand that when you hear one story, you've heard one story. I'm going to share my story. I tell people, I don't use years anymore. I use levels because it sounds really cool as opposed to years. Like I'm level 53. I mean, that sounds so much better than I'm 53 years old. I'm level 53. These are pictures of me back when I was level 2 and 4. That's my big brother. That's my mom. And one of the reasons I start out at this age is it's always this unusual tension that people have when they talk about LGBTQ folks. And they're always like, when did you know? And they make it seem like you have to have a long, huge story or otherwise you just made it up when you were, 35 years old or something. And I always sort of question that. It's not someone else's role to validate my label. I am one of the people who has known since I was very small that I was lesbian, but that shouldn't play into how I'm engaged in the world. I always tell people, I was born Black and I chose to be a Buddhist. You shouldn't discriminate against me for either one of those things. So what is the difference whether it's a choice or a genetic thing? Honestly, I don't think people have the right to tell other people whether or not their gender, their orientation in any way is valid according to other people. It's valid according to me. One of the things I always get actually is since I'm very masculine presenting, a lot of times people, they try to tell me, they're like, oh, you're trans. I'm like, no, I'm not trans. I know a lot of powerful and amazing trans people, and I'm not one of them. I'm a powerful, amazing butch dyke. And that should be on my actual business cards, actually. As you might notice, most of these pictures, if they're pictures that are photographs, they're pictures of me in various stages of becoming a total badass. This is me when I was I think, 8-year-old badass. And I was very aware at this point that I was lesbian. I was also very aware at this point that it wasn't something I was supposed to share with people. This is back in the 70s, which was in the last millennium, for those of you who are unaware that there was a millennium before this. And this is one of the interesting things about being not heterosexual, is that there's a point in your life when you have to start making choices about who you tell about who you are. And that is a consistent daily stress. Whether or not you're willing to admit it, it exists. And as we've known with racism, chronic stress contributes to significant health disparities, in that when you're in a situation of oppression, you're constantly under what we call allostatic load, which is basically stressed out by dealing with the way that society treats you. And it starts impacting people's health outcomes, even at this age. I was very fortunate. I was quite accepted in my neighborhood, because back then it was, I was a tomboy. You were allowed to be a tomboy. Especially, I grew up in Oklahoma. I grew up in a college town, and Norman, Oklahoma is very, very, very attached and affectionate to football. And it may or may not surprise you, but at this age, I actually started out being a really excellent football player. And it was full contact football, and they didn't care if I was a girl as long as I could knock people on their ass, and I could. And I played all the way from 4th grade to 6th grade. And I remember I was nose guard, and I'd switch off with the other nose guard on defense. And his name was Jeff Lewis. And I remember him coming out, because when nose guard goes up against the center, and Jeff Lewis comes out and he's like, "Hey, Crichlow." I was like, "Yeah." He goes, "The center wanted me to tell you, he doesn't mind that you knock him on his butt every time, but please stop saying excuse me." I'm like, "Oh, I'm sorry." Because in my family, when you put someone on their butt, you're supposed to say excuse me. I was raised to be polite. I was also raised not to necessarily turn out the way I did. This is me in college, and starting to embrace the fact that I got to buy my own clothes and my own transportation. One of the reasons I put this up here is that a lot of times in the early years, folks who are LGBTQ find that they have to find their own communities to find support. At this point in my life, my folks weren't as pleased with the fact that I was an open out lesbian. When I was 18 years old, I remember rolling into Boston and stepping off the T and just saying to myself, I'm never going to be in the closet again. And since I dressed mostly like this, it was clear to me that a lot of people were like, Renee, you were never in the closet. What are you talking about? But it was a huge relief for me. But one of the things I needed is I didn't have any health care. I had no health insurance. And young people of color who are LGBTQ are more likely to be uninsured. And that puts us in a very significant deficit just to begin with. The idea that you can't even necessarily get preventive care. When I was getting older, I was in college and I wasn't quite able to finish my degree based on the amount of money I had. So I had to go out and get a job. And I got a job at a place called Fenway Community Health Center. And I was a phlebotomist. And at the time in the mid 80s, Fenway Community Health Center was the leading AIDS and HIV care center in New England. And I was finally in an atmosphere where being a queer, being lesbian, being a little baby dyke was completely accepted. And it blew me away. It was one of those things where you never realize how much pressure you're under until that pressure goes away. And I had health insurance. So I could do things like get pap smears. I could do things like get my immunizations. I could do things like make sure I was treating my depression. And when you don't have access to those kinds of things, all of that contributes to health disparities with LGBTQ communities, especially the younger folks. It's a time when you're most vulnerable. You have no safety net a lot of times because your family doesn't necessarily engage with you in a way that would provide a safety net. I always felt like if I didn't get second chances, if I'd fall, I would not be able to get up. I was very fortunate in that I had a community of people around me who we started taking care of each other. And when you have your found family, if you fall down, they'll help you get up. Not everyone gets to have that. I was very fortunate. So I graduated college and I went on to medical school. This is my medical school housemate. His name is Dr. Ed Lim. This is before we were esteemed doctors. We were the MCs of our talent show. And Dr. Ed Lim, when he and I were matched up for roommates, I got a phone call from the dean's office on a Friday. And I had been waitlisted for UC Davis. And I was, like I said, I was always out and open. And I went to my medical interviews clearly an open lesbian. And it was even something that came up during the conversations in my interviews. I got waitlisted for all of my medical school, but I don't think it had anything to do with that. I think it had to do with the fact that I put in my application on time, but right near the deadlines. So I got waitlisted at all these institutions. And I got a call from UC Davis on Friday morning. And I said, hello. And they said, we'd like to offer you a position at University of California, Davis Medical School. I was like, wow. And I said, well, when does it start? And they're like, Monday. And I said, in 2 days? They're like, yes, in 2 days. I said, can I think about it? Because like I said, I'd been waitlisted at multiple places. And they said, you have 10 minutes. And I was like, okay. And I got off the phone and I spoke with my partner at the time. And she was like, you loved it there. Why don't you just go there? And I was like, well, what if I could get in somewhere else? And she's like, what do you really want to do? And I thought about it. I was like, I really want to go to UC Davis. And I called them back within like 3 minutes and said, hey, I'll take it. I'll start on Monday. And then the assistant said, oh, they want to talk to you because there's someone looking for a housemate. And you guys might be perfect for each other. I said, oh, great. And they give me the number and I hung up. And my partner at the time said, what was all that about? I said, oh, well, they think they have someone who I might be a good fit for a roommate. She's like, what does that mean? I'm like, oh, it means they're either Black or gay. And so I was right. I called up Ed. And like I said, this is before we were doctors. So I called up Ed and I said, hey, yeah, can I move in? And he's like, yeah, no problem. And one of the challenges is I have I may be masculine presenting in person. My voice on the telephone, everyone always thinks I'm a guy. And when I got to Davis and I was starting unloading, Ed looks at me and he's like, oh, I thought you were a guy. And I said, no, it's just my voice. He goes, I thought you were a straight guy and you were coming up here with your girlfriend, but I didn't care. I really needed a roommate. But one of the things I want to point out with that is it was priceless for us to be in a very challenging place, supporting each other. The fact that my housemate was Dr. Ed Lim made my medical school time so much better because I always had a place where I could just let my hair down and just be me. And sometimes that meant dressing up in ways that I don't always dress up. This was us letting our hair down at one of our, I think it was a Halloween party. And I bring this up to the idea, it's like, we were the only queer people in our entire medical school. And I'm not just saying our year, it was our entire 4 years. We were the only openly gay people. Oh, sorry, there was one other openly gay woman and her name was also Renee. And she was a white woman and she was from the Netherlands. And it was very interesting watching people trying to parse out which one of us they were talking about without saying race. This is really sort of interesting because intersectionality really plays a role in how we present ourselves and how people see us. And Renee, the other Renee, was white and she was European, literally from Europe. We both had short hair. We're the same height, basically same weight. And you hear people talking, they're like, oh, so I'm going to ask Renee. They're like, which Renee? And they're like, the short hair. They're like, they both have short hair. The lesbian, they're like, they're both lesbian. And there's like the Black one. And it was one of those things where you started realizing race is such a huge impact on all of the things that we do in our country. And in medical school, in our training, race, gender issues, queer issues, especially at the time I went through, you just didn't talk about it. They were all swept under the rug. And that reflected on how well our patients were taken care of. That reflected on how safe and trusted, distrusting our patients were towards the medical system, with good reason. They weren't valued. They weren't even acknowledged, except for at times in books of psychiatry in which they were pathologized. And that has been the most long-standing tradition in our culture in medical school and in medical training and in our health systems. And I don't dress like this as much anymore, I'm not gonna lie. So when I think of my medical school, the biggest thing that I understand about being queer at the time that I was there was I was fortunate to have a safe place. And I was fortunate to have someone who was always at my back. And Ed, when he came to medical school, decided at that point, he's like, I will never be in the closet again. And I had to let him know that he never actually was in the closet, because he would say things like, enough about you, let's talk about my hair. It was very straightforward and supported. We always knew he had each other's back, but literally at the time, there were 3 openly gay people in our entire medical school. That is my cat. Sorry, that is a bear. This is my cat, sorry. So graduated medical school, went to UC Davis for residency, trained as a family physician, got on faculty as a family physician. And then, of course, because I was a Black lesbian, I moved to Montana. And this is my backyard. This is a bear that would occasionally come in our backyard and just sort of, I think, show off. He's like, I'm in the backyard and look at me climb things. But it's sort of an acknowledgement that I wasn't in the same place anymore. I'd gone from a relatively progressive environment to a rural town. I lived in a town of 2,500 people. And I taught in Billings, which was a much larger town, about 100,000 people. But all this to say, one of the things that was very interesting for me was finding out how people in rural environments dealt with both the presence of queer people and being queer. I had many patients, not many, I had a significant number of patients who would drive to see me from 4 hours away, because they'd heard that there was a lesbian that was a doctor. And it was the only place that they'd felt safe even mentioning it. I had one young man who basically I was treating for anxiety, and he would always talk about how loving and amazing his family was. And I said, well, can you come out to them? And he's like, I can never come out to them. And the sort of dichotomy of being in what he thought was a very loving family and not being able to be himself was ripping him apart. He, like many folks, had issues with substance abuse, alcohol use disorder, polypharmacy, these kinds of things. And it really struck me as like one of the biggest things that folks didn't have was a sense of community. And that's one of the big challenges. Like I said, I was really fortunate. Most of my educational career, I've had people who I felt supported by, who may not have been exactly like me, but they were like me enough that we formed a family and community that we'd support each other. The isolation leads to many, many different health outcomes that are not good. And generally, as I mentioned, you'll see a higher percentage of substance abuse disorders, mental health disorders such as anxiety and depression that are honestly directly related to the long-term, long-standing inability for people to have a supportive environment around them, and their response to the oppression that they feel every day. I was lucky. I had a very supportive community, and to the point where I decided I wanted to have my son. This is my son, Amos, when he was I want to say maybe 4 months old. I lived with his fathers, a gay couple, and my partner at the time. And when I was level 40, I had a son. And it was actually quite interesting, birthing as a masculine woman. One of the issues that I ran into was getting clothes as I got more and more pregnant, because no one considers the fact that you may not be wanting to wear large frilly flowers every day of your pregnancy. So I went to the big and tall store, and I got what my friends affectionately called daddy sweaters. I got all daddy sweaters, and I had some black maternity pants. And that's what I wore the whole time. And it was really interesting. I would be in a situation where literally people would be calling me sir, and I could feel like a knee move across my belly because my baby was inside moving. And I was like, well, that was interesting. I had a very supportive physician and a very supportive birthing environment, primarily because I was very fortunate. I'd actually trained the physician who was my doctor when I was in the process of birthing. It was since I taught at residency program, I trained a physician that managed both my labor and my delivery. And I delivered in a place that I was a physician. All the nurses knew me. All the doctors knew me. And it turned out to be a great experience because I got our son, Amos. But I had, like many women of color, I had a pretty precipitous crisis-driven delivery. At one point, my son's heart rate just plunged, and we had to do a crash C-section. Everything turned out okay. Interesting enough, it's more likely that being a woman of color that I would have those kinds of birth outcomes. We turned out okay. And this is Amos a few months later. I have no sense of smell. And so whenever I thought that he might have had a bowel movement, I had to check visually, which is just so much fun. I bring this up though, because one of the areas there's a big challenge in the LGBT community is birthing. There are people who experience a significant amount of emotional trauma, a significant amount of direct oppressive involvement with the healthcare community, people who are looking to either find ways to get insemination or even where they're going to be birthing. One of the most unfriendly places for trans people is the labor and delivery. And that should be one of the most safe places for anybody. If that's where you're birthing your child, that should be a place where you feel absolutely safe and secure. And that can be one of the most threatening places for a lot of folks who are queer, and definitely a lot of folks who are trans in my experience. I got to the point in my life where my family was very, very supportive. Apparently the thing I had to do for my mom, who's pictured in this picture, is to actually just give birth to a golden grandson for her. And as I got older, it's one of those things where back when they had that YouTube campaign, It Gets Better, to help young queer and trans youth understand that their life is not always going to be the way it is at the point in time. My life did get better. It's got significantly better. And I'll be really clear, I'm one of the most grateful people on the planet. My life is awesome. And one of the big reasons is my family and I grew to accept each other for who we are. My mom is not perfect. I am not perfect, but she finally got to the point where she'll straighten out my pocket square and buy me boxer briefs for my birthday. So we worked on getting to know each other. So it's a little bit of just my story in those ways. And the reason I do is, like I said, I think one of the most important things to understand is when you've heard one queer person's story, you've heard one queer person's story. We all have different experiences. There may be some similarities, but you must value that person from their own perspective. This is one of the artists that I'm showing the pictures from, and Mir Kadar, trans person of color, and I asked to present their artwork, and I also said, well, this is what I'm lecturing about. What is it you think health justice should mean to the LGBT community? And they said, health justice is about uprooting the societal structures and systems of marginalization present in the healthcare system. And I thought that was just exquisite. It really crystallized a lot of the things that all of academia has been discussing when they talk about LGBTQ and health justice. It's really about the marginalization. And when you think about communities, when you think about the idea that when you marginalize someone, you're pushing them to the outside. Or actually, you've created a place they can't get into, and they're standing at the outside. Either way, that margin is a very dangerous place. It has horrible health outcomes. You're more likely to die. You're more likely to have to deal with substance abuse disorders, mental health disorders, cardiac disease. You have a challenge even addressing your reproductive rights. The margins are a very dangerous place, but they're also, honestly, they're one of the places that give you a hint on how healthy the entire system is. If the margins could be thought of as anything, think of it as the canary in the coal mine. For those of you who know, you understand that the idea that they used to take canaries in cages down into the coal mine, and the canary would be there, and their metabolism was much faster. So if there was any sort of dangerous gas or anything in the air that was bad, they would feel it first, and they would have the worst outcomes very early. And then the coal miners would be like, the canary's having trouble, we're out of here. Or the canary's dead, we're out of here. The folks at the margins, I really believe, are the canaries in the coal mine for our entire health system. The fact that they are engaging with the challenges that they have, even the victimization and the suffering they have to deal with because of the way the health system's set up. I do believe that they are the ones that are acknowledging the presence of a very sick system to begin with. The system does, our health systems don't work. And when you're at the margins, they work for you evenly. They work less for you.
5 minutes.
So, thanks. So one of the things that I looked to do was, I said, okay, what are other people's ideas are? And if you see anybody in this feed that you find interesting, I would encourage you to follow them. So I asked GayMed Twitter, I said, what does health justice mean to you? And got replies like, it means the requirement med schools to teach about LGBTQ health disparities, how to talk to patients with openness, gender neutral terms, how to take non-judgmental sex histories to all students. Big topic, but I think in primary care, it starts with asking, not assuming. And I think that's critical, asking, not assuming. Asking people their names, their pronouns, their orientations, their habits and supports, and challenging openly and without judgment. Huge. And then we get to the point where people are like, I feel strongly that medicine must take responsibility for the abuse perpetrated towards LGBTQ people. Feel very strongly about this. Agreed. In our current state, medicine is not trustworthy. We need a system that is worthy of our trust, our stories, and our bodies. That starts with accountability for past harms and an end to pathologizing and medicalizing queer and trans identities. A lot of it's a recommitment to a community-based care. Too much of the curricular work is on the abstract, on the theoretical queer person. without comments from the institutions about uplifting actual queer communities. Partly due to academic LGBTQ spaces being dominated by white and Asian folks without more expensive view towards intersectionality, understanding how the thread of queerness both ties and divides our community. And lastly, it talks about including and protecting trans kids from policies that threaten their access to healthcare. Bring this up because, as I mentioned before, the idea of where we've been in healthcare and health systems and where we need to be, we have to understand that there's been abuse, and health systems, our healthcare system is not trustworthy when it comes to folks that are at the margins. When we want to address these changes, we have to shift our focus. We have to make centering at the margins our priority. We have to make the people that are lying at the edge of our healthcare. If we can provide trusting, safe, supportive, and effective healthcare to the folks at the margins, it's going to improve the entire health of the rest of our society and community. We have to understand that when we center at the margins, we improve it for everybody, but we save the people who we have actually been abusing since our health systems began, actually. This article, I highly recommend reading. Talks about the different intersectionalities, and it really expresses, as I said, my opinion that the folks that are most marginalized in our health communities are the ones that, when we create a safe place for them, it's going to be impactful on all the other structures we have. We have to stand up for those who are most vulnerable, but we have to also realize these are strong people. They've survived. The fact that Stonewall was started by a trans woman of color. The fact that many of our movements for social change right now, people in the vanguards, many of them are queer and trans. The fact that we're not looking to be saved by the cis heteronormative community. We're actually looking to destroy those structures because they don't work, and they don't work for any of us. What works for us is when we take care of each other, we keep each other safe, and we build communities. And we build communities within healthcare organizations that impact and change those organizations. One of the things I talk to people about is, yeah, when you're queer or trans, it's hard to get in the door sometimes, but you do whatever you can do to get your foot in the door, and then you rip those fucking doors off the hinges so that other people don't have to go through them. But we're there to protect each other. One of my favorite quotes, function of freedom is to free someone else. Indulgence is self-love. This one's called communion. And when I think about this, I think about the fact that there's a lot of trans and queer youth that go months without having a caring, touching person in their lives. I love the artists that I've chosen because I feel like every single painting that they've done is just demonstrates so much strength. And that's what we need. We need to acknowledge that the folks that we serve in medicine have strength beyond what we imagine. And we need to incorporate that in the way that we work with them and listen to them. It's powerful, beautiful. And when we open our eyes to it, it's going to help all of us. Being fierce is a big part of surviving as a queer person. But I have to say, this world and our health communities should be a situation where you don't have to be the fiercest badass on the planet. You can just be yourself, whatever form that comes in, and you should be able to be cared for. So when I think about health justice, those are the things I think about. What do we actually have? What do we actually demand of our people? And how many people do we actually just let be themselves? I will tell you that one of the things I think is very important is when I use Black artists, people of colored artists, queer, trans artists in my presentations, I always make sure that A, they get the credit, and B, they get some of the money that I get, because otherwise you're just tokenizing and using people, and that's inappropriate. Time we start centering at the margins, and start engaging with communities instead of dictating to communities. It's time we start listening to hear and understand instead of listening to respond. And it's time we understand that we have been untrustworthy in medicine, and it's our duty and responsibility to rebuild that, to build that trust with communities that are LGBTQ and communities of color. And that intersection is probably one of the most crucial ones too. Remember, the people we're dealing with, they have strengths, and we have to acknowledge and admire and appreciate that. And we have to work together. And it's not about us fixing them. It's about us working together and collaborating with them to build a healthy future for all of us. This picture started it with it and ending with it. It's called We Never Ask Permission. And it is a picture of trans women of color just caring for each other, and multi-generational. And I think that it's exquisite. I think it's beautiful. And I think that that's the future that we should all strive for, is a place where we can feel this without the oppression, without the disparities and inequities that exist now. So this is me, queer Black woman in academia. And I'm glad that I got to tell my story. It's not the only one, but it's the one that I get to share. And so thank you. Thank you, thank you.
Thank you, Dr. Crichlow, for a fabulous presentation. Now our chat monitor, Rachel, will be taking questions from the chat, or feel free to raise your hand and we can request to unmute you. We have about 12 minutes to answer questions, so we can get a lot covered.
Okay, we have a few questions in the chat already. The first is, are there any institutions, hospitals, or programs that you have heard of that are supportive of trans pregnant patients?
Okay. Not full institutions. Everyone's, okay, and I'll be clear. There's people who, everyone says they support everybody and everything they do. And we know that's not true. But there are, I'd say, in my experience, there are little niduses of supportive environments. And it generally reflects around a certain clinic or a certain group of clinicians. East Coast is very easy. New England's very, Boston is Fenway Community Health Center. Where I live and am moving from in Minneapolis, there's a few, there's Smiley's. Smiley's Clinic in Minneapolis is amazing for trans birthing. They are very good for that. And there's just what I'd say is sporadic clinics around the country. And it's really about getting in touch with the community there. But those are two places I know. One in Minneapolis that's extremely trans-friendly for obstetrics, which is Smiley's, and another which would be Fenway Community Health Center in Boston.
Okay, next question. Any advice for queer medical providers and their concern for coming out in a new medical institution?
So I tell people, it's like, you have to decide who you are. You have to decide what you're willing to do and what you're willing to be. Because as I said, when I was 18, I said, I'm never going to be in the closet again. And so I won't work at some place that wouldn't take a tie wearing Black lesbian. Like that's how I show up at the interview. And if they don't want me, they don't want me. But there are times where, you will be in an environment where for some people, that's actually, they are learning and they're coming out and they're already in an environment. What I would say is find people who seem like they might be supportive and engage them in your life. And if you can step out with and come out with some of those folks, it might make a more supportive environment around you. But I'm the kind of person, honestly, I believe that you get the community that you build. Every job that I've ever been at, whether it started supportive and caring, it ended supportive and caring, because I was one of the people that helped make it happen. And like I said, I've lived in rural Montana. I had clinics in towns of 900 people. The advice I give to folks: find support, supportive network, and find out who and how you want to be. And in my experience, when you're open and out at the beginning, it makes it all a lot easier. And honestly, like I said, don't work someplace that won't accept you who you are. Just don't. And, don't. It's just not worth it.
Okay, thank you. Next question. Sex assigned at birth is inherent to medical forms, but its use is often irrelevant and can be harmful to trans patients, especially when knowing medication history is more useful. Do you have any input for how to address or incite changes to these components of the healthcare system?
I would say that one of the things that's happening now are people trying to find ways to be more inclusive. And it's very baby step oriented. The fact that I can now go into my electronic medical record and give preferred pronouns and preferred name, that's huge. And I think that took like 10 years or something ridiculous. It's really just going to take people continually engaging with the systems, and actually, honestly, getting into positions of leadership. The further I get up the food chain, the more stuff I get to influence. So, don't let me be up there by myself. I'll need everybody's support. And my goal is to push all of you up above me so you can lead the way. But honestly, get in positions of leadership, and wherever you are, impact what you have the ability to impact. Use what you have, do what you can. And that's what I really believe in.
This question actually follows up on that, getting into leadership positions. Do you think that queer mentorship is valued enough in the medical field? And then actually one that goes with that is, what are some things that you stressed in the training of your provider who delivered your baby?
Oh, okay. So mentorship is something I highly value, and every learner that's ever engaged with me has been taught that mentorship is important. One of the mottos that I always teach by is lift as you climb, build as you grow. And anyone that's ever spent more than two rotations with me is able to say that and do it. It's not valued in academia in that it doesn't benefit the mentor except for the engagement with the learner, which I think is powerful and wonderful, but it won't advance their career in any way. But honestly, you don't do these things to advance your career. You do these things because it changes the world. Every person you mentor helps change the world. What did I teach the doctor who delivered my baby? Actually, the same thing I taught them about everybody. It's like every single person that you get to care for, and we're family physicians. We do full spectrum from prenatal care all the way up to hospice, and everything in between. And every single patient, when I'm teaching folks, I'm like, every person that you're caring for is a sacred honor, and it is your duty to see them in the most compassionate, caring way possible. We can't always cure, but we can always care. And one of the biggest ways that we demonstrate our caring is listening to our patients, listening to what quality of life means to them, listening what their values are, and helping them fulfill what they believe is success, not what I believe is success. And also, when I was delivering babies with her, I noticed that she was when you push really good in pregnancy, when you're in labor and you push really good, a lot of times there's just a little poop that slips out. And she was just very graceful in it just sort of went away. And she was just created this kind, loving environment, and everything that could have maybe embarrassed the patient, she always made sure it was a safe environment and the patient was safe. And I was like, when she graduated, she's delivering my baby, and she did. So that was fun.
Okay, and how can cis providers create a more safe and comforting environment for LGBTQ patients?
Okay, this is going to sound just trivial as fuck. I apologize. I haven't slept much. Honestly, those little badges, little rainbow thingies, the little she, her things, when, you know, maybe not for someone old and jaded like me, but honestly, when you see the looks on the young queer kid's face when one of the docs walks in and they know that this person, they may not be perfect, but they're trying. They're trying. And when you make a mistake, when you mess up, like when people misgender me, just apologize and move on. I don't need you to make it about you, about, oh, well, the reason I did that was because I'm like, I know why you misgendered me. I am wearing expensive Brooks Brothers clothing. Trust me, this is not an accident. Don't make your apology about you. Acknowledge that you made a mistake, move on, and say, I'm going to do better next time. Thank you. Yeah, just that's the biggest thing I'd say to cis docs. Wear some bedazzled stuff that says queers are okay. Have your pronouns. And when you make a mistake, just apologize and move on. I think those would be very helpful. Those were always helpful for me.
That is great. Thank you. We have another question. Do you know of any medical schools and residency programs that actually prioritize teaching proper LGBTQ plus care and treatment? And if not, do you have any ideas as to how this can be addressed and incorporated into existing programs?
Okay, well, I'm going to tell you something that's going to be very, very surprising to you. The medical school that leads the country in this is actually the University of Minnesota. We have actually what's called the Program in Human Sexuality is one of the departments, and that department is nested within the Department of Family Medicine. We have one of the most robust human sexuality, human health, sexual human health. I don't remember the name of it. You get the idea. We have one of the largest parts of our curriculum. It used to be like a month and a half or something like that. It's been condensed, but it's still like 200 hours and it's longer. It's probably 80% longer than any other medical school. And it has lectures and small groups. And as a result, the folks that train the U for med school, most of them actually stay in Minnesota in the residencies. So like, honestly, we have 7 residencies at the University of Minnesota that are all family medicine. And every single one of them would be queer and trans friendly. Some of them actually very focused and prioritizing trans care, like I said, smileys and things. But the fact is, you know, we did a study and it's like, we actually have the most curriculum on human sexuality. It's about learning the jargon, learning the data, learning how to create a safe environment for your patient. And I've taught at that class was the lead physician for the last 8 years in the lecturing. And one of the things we express is like, you have to understand your duty as a physician is to create the safe space so that this person feels that they can trust you with their life. And one of the things I tell them is, if you can do that for a young trans woman, if you can create that kind of safe space, every one of your patients are going to feel safe because you have the ability to do that kind of caring, supportive, trusting environment. So it's a skill set that is transferable and very important in every part. So it can be done, and it needs to be a priority in other medical schools.
Thank you so much, Dr. Crichlow, for your time today, your incredible presentation, and your really thoughtful responses to our amazing audience's engaging questions. And thank you so much again, Dr. Crichlow.
Thank you, guys. I appreciate it. It was an honor.